Welcome to Nurse Practitioners Changing Practice. I'm Dr. Carol Berger.
Hi, I'm Dr. Nina Zimmerman.
We are so blessed to have Margaret with us again. Margaret Bentz, you are just a dynamite person and you are working so hard for nurse practitioners.
Yes.
It's
Thanks,
really
Margaret,
nice to be here with you guys.
Great. Thanks for being back with us, Margaret. We really appreciate it.
You are so involved with our legislature. So what we are so excited to hear about is, we have to have you on every year to give us a legislative update. What's going on in Missouri? What are the bills that are going through? What's the scoop? We've certainly had a lot of changes with COVID.
Yes. We actually had a lot of changes with COVID because we're such a restricted state that we had a lot of waivers go in, more so than any other state, because everybody else has so much more practice authority than we had. And full practice authority states didn't have to make any changes, but we did. So we are trying to make those waivers permanent because they abruptly ended December 31st without warning. So yeah, that's part of where we are.
So what are some of the waivers? Tell us what waivers Missouri had to go through.
Okay, the waivers that we had were that we didn't have to have 10% of our charts reviewed. We didn't have to work with our collaborating physician for the 1 month time frame before we signed an agreement with them because they wanted to mobilize people quicker. We had the ability for everybody to do telehealth originally, and what our statutes are in Missouri is that you can only do telehealth if you're in rural and you're calling from a federally funded clinic or medical home in rural Missouri. So people in urban areas that aren't in federally funded clinics were really not able to do telehealth once December 31st came around.
So before December 31st, during our COVID time, telehealth was like everywhere and we could do it, right? Because
yes.
of COVID. But abruptly on December 31st, all of those things that were in place that were safe for NPs to do, no longer did they need the charts all reviewed. No longer did they need a 30-day, pre-author before they could be on their own with their collaborator kind of thing. And they could do telehealth all over because we were safe to do all of that prior to December 31st, 2021, but abruptly ends on December because now we need more supervision, right?
Yeah. Right. And the other thing was geographic proximity, which is in statute, was eliminated.
Yes.
And so we didn't have to stay within our 75-mile radius of our physicians. And so all of those things we were told by the governor up to 1 week before he was going to extend. And then at the last minute, without notifying anybody, he called the Board of Nursing and the Board of Healing Arts an hour before he announced that tomorrow I'm ending the waivers. And everybody was floored because he had been telling everybody all along they would be extended.
And this is Governor Parsons, right?
Yes. And this is when numbers were still really high at that point.
Do you have any insight of why you think that was reverted back?
I don't know, but there was no talking to him about it. And with that state of the emergency ending, and he ended all our waivers, in addition to that, it ended the ability for hospitals to have pop-up areas or to convert a different area of the hospital. It made it so that you couldn't put like a testing center on the parking lot. Remember how they were kind of trying to test?
That all stopped.
That all stopped because the state of emergency ended. And at the time, everybody band together, everybody wrote letters, the hospital association, the physicians, everybody said, extend all these waivers, extend the state of emergency. And he said, no, he just wasn't going to do that. I think part of it was federally influenced because it was all the Republican governors that did that.
Oh.
But who knows? He just told us no, and it was not negotiable.
So I'm kind of, I have it, but I don't completely understand. Prior to these waivers ending, we were safe to do all of the things they were asking us to do. Afterwards, we're not safe, I guess, because they want to re-imply the restrictions, which are supposed to make it safer for patient care, right? With physician oversight.
Well, and the physicians argued that
they just denied it, right?
Right. Yes. And some of that was that the physicians do not want, they from the beginning, they were not consulted when those waivers went in place. They wanted those waivers back in place because they truly feel that we are not safe and cannot do those things. Now,
Well,
a lot
we
of
were
the
safe
nurse,
when they needed us to.
well, and what happened was a lot of nurse practitioners were laid off during COVID,
Right.
remember? And so a lot of them opened in rural Missouri, especially, a lot of them opened their own practices, and they had to go farther than 75 miles to find a collaborating physician because of restraint of trade and because of specialty and things like that. So they opened these practices and were providing their specialty care, and mobile vans picked up, and they started doing mobile vans, and they were farther than 75 miles away. So a lot of people went and testified and said, you abruptly ended this. Now there's a huge population that doesn't have health care. And that was a problem. And that was very influential, but we are still trying to get this legislation through.
So
we-
where are we at in Missouri? Are we
Right.
ever gonna see Missouri come up with the other states like that are all around us?
Not anytime soon, but we did put forward legislation, and it's HB 2371. That's home health, but I'll get back to that one. Let me go back to the ones with the waivers. So Representative Grier, who is very much about people need to have the ability to do what they're trained to do and to meet the needs of the people. So he sponsored HB 2434, and it was to get rid of all those waivers that we removed, to move them back in and make them permanent and take those barriers away. And we weren't asking for any additional barriers. We weren't asking for the signs to be removed or anything like that, or prescriptive authority. We're just asking for those 4 waivers. We had in the House is very functional, and they're moving things along and moving things through very quick. So we had a hearing in the House, and our hearing in the House on those 4 things was on, I think it was like February 16th. Actually, it went for 2 weeks. So it was February 9th and February 16th. And we had tons of support. I mean, tons of support. Rural Health came and testified. The Extension came and testified. Home Health, AARP, Americans for Prosperities came and testified. Department of Health and Senior Services, BJC, Mercy, Cox, Luke's, SSM, Mizzou, Behavioral Health, nursing homes, primary care associates, Missouri Home Health Association, Blue Cross Blue Shield, Amazon, tons of people.
All in our
lots more.
behalf to bring these 4 waivers.
Yes, for
Yeah.
these 4 waivers. And so we had all that, and the only people that testified against us were the DOs and the MDs. So we had some really good hearings. They said the same thing over one of the people that testified just started giving a litany of what she didn't like about nurse practitioners. And the sponsor said, have you read this bill? Because nothing that you're talking about is in here. And she said, no, but I read the title. So anyway, we had a very good hearing. It got out of that committee 13-1, with the only person voting against it was the physician on the committee. And it went to legislative oversight. Legislative oversight heard it on 3-3, and they voted it out with a 9-0 pass. So it is headed back to the floor. However, an amendment was added on, and to move it forward without being blocked, we, our legislator, Representative Breyer, who has been amazing. He understands what we want. He understands the problems. He understands why it's important. And so he's been really great. But what is left in the bill is the geographic proximity is still there. That would still go away. And telehealth fix would be in place so that everybody can do telehealth.
So we would be able to do the telehealth, but we would not be able to be beyond 75 miles. That didn't.
No, we'll still be able, it would
can't.
take, it's still in the bill is the mileage removal
Okay.
and the telehealth. So those 2 are
Okay,
in.
so those are the 2 main things. I mean, if they want to review 10% of our charts, that's fine.
And
Well,
crazy,
look,
'cause
the
most of the
month-
time they don't do it.
Yeah, the month with the collaborating physician before you can be on your own is tough too, but
Yeah,
Yeah.
but I mean, if you need to, you need to. I mean, but the main thing would be at least we can move a little bit easier. And the month, the funny thing with the month, it's so crazy because it doesn't specify how much time you have to
no,
spend.
it says,
You can spend 5 minutes with
says
them
1 month.
days.
But we very specifically fight for that every year because they always want to say 30 days and we always say, no, it's 1 month and you can't change it. And so we fight very hard to keep that verbiage in, because if it would ever go to 30 days, then that would be a problem. But as 1 month, it's vague. It could be the first and last day. It could be one day every
Right.
week.
Yeah, I mean, and they don't want you to be with them for 30 days.
Actually, they testified that they thought that that wasn't enough to know if we were safe. And so the legislator said, oh, are you saying this should be 2 months, 3 months? And they said, no, we'd lose so much money by having them just work with us for that long.
Yeah.
And so then he was like, you can't have it both ways.
Yeah.
So
And
it
they don't really
interesting.
want, I mean, my experience has been, they really don't want you right by their side to be able, but I mean, there is something to be said about the 10% chart review because they're paid for that, I do believe.
They're paid very well in rural Missouri. Not so much here in urban areas like St. Louis and Kansas City. It's not so much in the metropolitan areas because they're all over the place. But in rural, those guys, when they open up a practice and they have to pay a physician to come in and do chart review, they're paying them a lot of money.
So
And,
that's a motivator too. I mean, that's hitting them in their pocketbook and they probably don't want to let that go.
yeah, yeah.
Do-
So that's where that one is. What, Nina, were you going to say something?
Yeah, I just would like to know your opinion on, and I've asked you this before. So the MDs and the DOs that constantly, block us. I mean, do you feel like that culture is changing with younger DOs and MDs, or how do you think that's going in Missouri?
No, it's interesting because I think it's some of the oldest ones that are the more accepting. The younger ones coming out of medical school seem to be really adamant about upholding this and carrying this torch.
For Missouri, this is just
for Missouri. But in general, the Medical Association, the AMA, is pushing to pull and rein back in nurse practitioners across the country.
Yeah.
And so Missouri just happens to have a stronghold because we have so many legislators that are physicians. We have Dr. Onder in the Senate. We have Dr. Patterson in the House, and he's actually really good. He's really good to talk with. He's a general surgeon from St. Joe, Missouri. Senator White, his wife is a neurosurgeon. There's a psych mental health person that's on the committee in the House, Representative Thompson. Jeannie Riddle's son is a doctor. A lot of people have doctors.
We need to get some nurse practitioners on this committee.
We have one nurse in the House right now, and it's Patty Lewis. And she
Yes.
originally sponsored this very bill, and she's a Democrat, so it would have never gotten heard with her. And so this is a bipartisan with Representative Greyer and Patty Lewis, and Patty's been a champ for us. She speaks up at these committees, she explains things, she ropes things back in, and she's been really super. And Moni actually gave her an award for her advocacy on the behalf of nurses this year. So she's been really good. And so right now we need to be telling all of our local House of Representatives people to vote for this. And
what's the number of this bill? What is it called?
This one is 2434 in the House.
Okay, 2434. We need everybody to tell their representatives to vote for this bill so we can get back some of the restrictions that were placed from, the COVID, COVID era.
And there is no match to this bill in the Senate. We did not have anybody to represent or file this for us in the Senate. So this will do the normal process with crossing over chambers once it's voted on. And Senator Burleson says he will pick it up and carry it and perhaps even add his licensure bill onto it to move it forward. And that in that case, if it goes through with different words on it, then it would have to go to conference. And in conference, they have to make sure that the words on the bill in the House and the words in the bill in the Senate match. And then that's when it would be revoted in both the House and the Senate and then go. But realize last year we made it all the way to the floor of the Senate and then it was filibustered by Senator Onder.
Yes.
So hopefully this is his terms out after this year. And he's not been making many friends this year because the Senate in general has not been really functional. They are still arguing over congressional maps and the state budget. and they've really not heard many bills. And so as quickly as the House is clearing their bills and getting through them and hearing them, they're working like one of the bills I'm going to talk about was heard until 9 o'clock at night, 2 weeks in a row. And they're working really hard to clear things, but the Senate has not heard much of anything yet. And so it's, it might be a year when things get bogged up because the Senate has been so dysfunctional. We're halfway through, they're on spring break this week, and hopefully they'll come back and start working, because right now they've just been arguing. There was Bidgate and all kinds of other things where they just quit working and walked away. There was also bad weather that shut people down for a couple of weeks in a row.
So we really don't have a whole lot of this year left, right? Before they're.
The session ends the second week of May, and it has to end that day because it is in statute that it has to end on that day. So yeah, there's
what
not.
else is going on? We've got the one that may
Okay,
or
so
may not be heard.
That's that one. The other one that's important is that with the CARES Act that passed, I don't know if you remember, but the Trump administration had put through an executive order that allowed nurse practitioners to do home health ordering. And that went through with the CARES Act. They merged that into there. So when the CARES Act came out, everybody thought it was taxes and money and distribution and all that. There was a part from CMS in there that allowed nurse practitioners to permanently order home health. And so all states, except 4, adopted that. But our state specifically said in statute that only physicians can order home health in Missouri. So even though that was federal statute, because our state specifically had it in statute, then we have to go and get a word change. We have to get statute changed. So we filed last year. It was a 6-word change. It went nowhere. And so we refiled exactly the same thing again. And this year it's moving. It's moved through the House and it's cleared that very same committee. This one went through on February 14th with a 13-0. So nobody voted against it. It was voted do pass. It went to legislative oversight, passed 9-0. It's also headed back to the floor for a floor vote. And then it will cross over. The thing that's different about this, well, actually this one, almost nursing didn't get to testify on this because all of our support organizations, one after another, the Department of Health and Senior Services had collected data on how many hospitalizations and increased complications were avoided because nurse practitioners specifically had ordered home health and kept people out of the hospital during COVID time when there was no room in the hospital. So they had collected data, and all kinds of people had collected data on it. So they all testified, and we almost didn't even get a chance to testify on this, but it went through very easily. Initially last year, our hangup was that the physician said, we don't have any training to order home health. They tried to add an amendment onto this before the vote, but they told them they didn't get it in time. It had to be 24 hours ahead of time. They wanted it clarified that 6 months after the person got home health, they should see and review the chart. We told them they could put that in any collaborative practice agreement. You can put anything in you want, but it didn't get accepted. So it passed through cleanly. Now we have this running simultaneously in the House. This time it's SB 83, again with Senator Justin Brown carrying it. It went through the families. This is one of the bills that was heard, and it went through Seniors, Families, Veterans, and Military Affairs Committee. And it went through on 3-9 and was passed, do pass with a 6-0 vote. So it passed through easily. However, before it passed, it had an amendment to put that review within the CPA agreement and clarified what that meant. Now that means these 2 bills are coming through, and they're both passing through to vote on the floors of their respective chambers. And because the words don't match, they're going to have to go to conference. And then it's possible that we can get that back out again. But what this would mean is that not just physicians could order home health, it would be podiatrists, it would be NPs, it would be clinical nurse specialists, and it would be PAs, because that matches the federal legislation and the CARES Act.
Yeah.
One of the things
This
we heard in
sense.
Yeah, one of the things we heard in testimony was they said, how come APs aren't in? Well, APs aren't recognized federally. And so it's not in the federal legislation. And so it was not in this, and they accepted that and left them out. So APs would still not be able to order this.
APs meaning?
Assistant physicians, those are the
Assistant,
people that,
okay.
that went through
Physician
medical school.
assistants, but assistants, physicians?
Yeah, that's a
Assistant
different
physician.
role.
That's a different role. Okay, all right.
But they're in statute right with us. So they're treated exactly the same. So like when you can have 6 people to collaborate with, it can be 6 APs, it could be 6 PAs, it could be 6 NPs, or any mix of any of those to
Yeah.
equal 6. So they're equal to us in statute, but on this, they are not, because they weren't in the federal statute that we're matching. And so we left them off, and it stayed off because it was supposed to be matching the federal legislation. So that's where that one is. And hopefully when it goes to conference, we'll have strong enough people to get that silly language out, because really it's unnecessary, and putting more language in just means more language that has to be dealt with and pulled out some other time. So that's where we are with that one. Let's see, what else do we have going on? We got a bunch of stuff going on. So our licensure bills, we still don't have a license in Missouri. We're still in documents of recognition.
Right.
Now, the military, that committee that I told you, seniors, military, all that kind of stuff, that committee wants us to have a license, because that way military families, when they come in, they could have some kind of a compact thing where they could come in, and the families that are here for just 2 years would get their license right away and would be able to start working right away. And so they were trying to make things comparative, but for that to happen, there has to be a license for nursing. And right now we have documents of recognition, which does not meet and fit the bill for that. So they would like us to have one. The problem is, and even with our licensure bills, you still won't see a scope of practice. And the reason we don't have a scope of practice in there, it's very vague. Remember when you look at our statutes?
Right, yeah, it really is.
Very vague. We don't follow the compact, we don't follow the consensus model. We don't have any of that. And the reason is that if there's any mention of scope of practice that includes diagnosis, the physicians will blackball it and shut it down. They do not think that nurse practitioners can diagnose. In fact, in testimony, they said nurse practitioners cannot diagnose medical diagnosis. They can only do nursing diagnosis. And I'm texting Heidi saying, Heidi testified that we can do medical diagnosis. And she said, no, just wait, because it's a trick. If we say we can medically diagnose them, they're going to say they want us under the Board of Healing Arts. Medical, they want us under medical.
Well, how come when we see a patient and we put a diagnosis code, an ICD-9 code in, and we bill for that code and we get paid for that code, but we're not diagnosing?
And that's what they say, that we can't.
Well, what are we doing?
Well, if you look at the collaborative practice agreement, it tells you that we only do self-limiting. You really only are supposed to do self-limiting care.
Nothing new.
Why?
Nothing new.
Nothing
new.
Why are we billing for it? Why are we getting paid for it?
Well, and that's an interesting thing, because they want to maintain incident to billing, partly because they get paid reimbursed 100% as opposed to the 85. CMS wants to get rid of that. So I was just at the health policy conference in DC, and they showed us the data that nurse practitioners actually on the very value-based care perform really high. We're at 89% for the mean, I think. And on the median, it's 96%.
Wow.
We're well performing, and that's diagnosis and treatment. And that's hitting all those measurable outcomes that they look for the value-based care and incentive reimbursement. And so we are doing it. They just don't want to say that. And anytime we make any inclination to that, then they say, then you should be under the Board of Healing Arts. So then we go into our whole talk about why we're a different field. We would still have to be under nursing because we are nurses first with a second on top of that. And you don't, if you're under 2 boards, it increases the cost and the expense to the state, that they don't know our education and training, so they can't really supervise and enforce things. So now they're suggesting that we have a joint board just for oversight.
Oh my gosh.
They want a joint board for what now? What would
they want a joint board to agree on, like, management and treatment and where people can complain and things like that. That is just their suggestion. We just say, oh, okay, we'll think about it. But there's been a lot of issues going on between the Board of Nursing and the Board of Healing Arts, because remember I told you it's
Now, this is
geographic-
just in Missouri.
just in Missouri. Yeah,
Okay,
just
I
in
just want
Missouri.
to clarify for our audience, this is just a problem in Missouri where these two boards are not communicating.
Communicating.
The doctors and the DOs are having issues with, or not all of them, but some of them are having issues with nurse practitioners having more, more independent practice.
Yeah, right. And the problem, we do have some physicians from BJC called Mona and said, we want to testify on your behalf. We saw what happened during COVID and we need those people to be able to function that way still, and we can't. And so we do have a group of physicians that have called and asked us, what can we do and how can we support you? And how can
That
we
is
move
so
this
good to
forward?
hear.
So that was really encouraging. But in the meantime, we have these crazy rules. And so we asked, because in Missouri, our rules are jointly promulgated. And it's jointly promulgated between the Board of Nursing, the Board of Healing Arts. And if it's a pharmacy information, then the Board of Pharmacy is also included. Board of Pharmacy always goes with nursing. They always support us in the things that we ask for. But the Board of Healing, so the Board of Nursing sent a letter to the Board of Healing Arts and said, we'd like to discuss the 75-mile rule because it's only in rules, and rules we can promulgate. And in statute, it just says geographic proximity. They did not respond. So they sent it again, no response. So then they went to the governor and he said, I don't really want to get involved in this right now. So then they went to the legislators. 23 representatives and senators wrote letters to the Board of Healing Arts, urging them to meet and discuss and negotiate with nursing. They still didn't respond. So then our legislation started moving forward and they saw that things are going to go away anyway. And so now there's going to be a joint meeting from the Board of Nursing and the Board of Healing Arts on March the 21st, and a second one on March the 28th that we can all listen to. So if you want a link to that, I can send you the link and you can listen in.
Yeah, and
we'll all be in listen in.
Pod.
Yeah, we'll all be in listen in mode. And in the listen in mode, though, we can write ahead of time to the Board of Healing Arts and the Board of Nursing. And the Board of Nursing wants us, anything we send to the Healing Arts, to send to them so that they can say, we know that you got this letter. But we can tell them our stance and what our feelings are, and they will represent us then. So they're soliciting letters for that right now. And if you're a MONA member, you got a solicitation letter yesterday in your email asking you to write about, especially the 75 miles, because that was a randomly picked number that was randomly changed at one point in time. And so one meeting is about the 75-mile thing. The other meeting is because the governor proposed that, okay, I get you guys aren't getting along and you're not talking. So the governor proposed that the 75-mile rule go away for anybody working in a correctional facility. And he said, I urge you to take this because I'm giving you a piece, and then it will be a foot in the door and we can see where it goes. And so nursing was ready to take it. And the Board of Healing Arts said, wait, we have to check. We don't want correctional facilities think that we're giving them subpar care. So they wanted to meet with the correctional facilities, and then they're going to meet on the 28th to discuss that topic. So there's two meetings finally set up. Now, last time Senator Burleson pulled everybody in his office, they said, we want them under the Board of Healing Arts. We want a stronger collaborative practice agreement. And they named 4 things that were ridiculous. And we said, no, we can't, nobody could agree on anything. So they said, okay, we'll wait till we have these meetings coming up. So there's a mediator that will be on those meetings. And I will send you the link as soon as we get off of this, so that you can tell people how to listen.
Have that link posted right in the podcast description, so that anybody can listen in and see what these meetings, what comes out of them.
Kind of crazy. So the other thing,
so those meetings are going to be trying to get rid of the 75-mile rule.
Yeah, because it's just a rule.
It's just a random number.
Random rule. Yeah. Yep. So the first one is specifically about the 75 miles, and the physicians really don't want to give on that. And they really don't want to give on any of it. Because
why do you think they don't want to give? What is the underlying, what is it that they are worried about, or your perception from all the negotiating? Because you're so involved in hearing all of the arguments. Yeah, what is their biggest objection?
They say we are not safe. And there is actually no data. So now the legislators have heard us say that and we've given them multiple data, and we've given them the CMS data. And they say
And
that
then
we
the
won't go to
measures,
rural.
we score high on the measures.
And then all the,
Value-based care, I mean,
right.
very high.
54 years of data we've collected that shows that we perform equal or better on the things we are trained to do. And so, yeah, they've had more education. They have the full breadth of medicine that they have to cover. We have this part in our specific scopes that we cover, so we can do it in a shorter span of time and be very good at it. So diabetes, congestive failure, hypertension, we shine in those areas and we outperform them in those
Well,
areas.
we really like to teach too. So teaching
Yeah.
patients is what we've done ever since we were in nursing school.
Right.
You know, like one of the things I like to tell our students is in nursing school, all that first 4 years, like when we would have, if we were going the medicine track, we would have been, you know, studying science. We're interacting with patients and learning
Right.
how to teach. So that those first 4 years of our education, we really do learn a lot about interacting with patients and assessing them and doing physical exams on them and teaching them about their disease processes. And that never gets counted.
Well, and
Just
we
the
do
medical
all those
school and
hours.
after, but we have it from the first moment we enter school.
Right.
And there's all those hours, and there's the practice where most of the time we're practicing full time while we go to school.
Right.
So it's not just the 750 hours that we get during our
Right.
time, or the 1,000 hours if you're a DMP. It's not just those. You have to look at the whole picture. But they say in your NP training, you only got this. So they don't think
They don't
continue to
consider
say
all of those years and time where we learn diagnoses and medicines and physical assessment skills. But more importantly, we learned how to build a relationship with our patients. And the more I learn, the more I hear, the more data I look at, it is that relationship,
Yes.
being able to connect to your patient. And not that the physicians can't, but we've had practice all through our nursing career on how to build that relationship of trust and collaboration with our patients. And that does a lot to help patients learn about their disease and help to manage their disease themselves.
Yeah. And that's our
And I
model.
think that's why we get
That's our model. That's the nursing model. It's a more holistic approach.
I think that's why we get better outcomes, is because of the teaching aspect.
But also we're focused. I mean, we have a certain age groups, we have certain things, we know what our red flags are and when to refer. In states that have full practice authority, the physicians do not see as many patients, but they see the more complex ones. So they end up seeing fewer patients and making higher income because they're more complex.
Well, and and they can then focus on the things they love rather than doing, you know, and we can focus on the things that we love. So I just feel like there's got to be space in this world for both of us.
Right. Well, and there's a huge shortage. There's a huge shortage of primary care physicians, especially in rural. We have a lot of shortage still, and the numbers aren't getting better, they're getting worse.
I'm old enough, and you are too, to remember when DOs had this fight with MDs.
It was the same kind of thing, different model.
They had that Normandy Hospital was the only hospital that DOs could practice in because they couldn't practice in any, they couldn't get privileges at any hospital because the argument back then was a DO is not equivalent to an MD, but they bridged that gap. And now they see each other as equal. I see them as equal. And we're now fighting the same fight.
Yeah, it's interesting. So there's crazy stuff. And when we say now, the legislators are starting to say, where's your data? Where'd you get that from? And the good thing is our data isn't just nursing data. The Institute of Medicine is very supportive, and they are the ones who advise Congress, and they are now with the new one.
Be allowed to practice to the full extent of and that was what, in 2010?
Well, now the new one came out, and that supports us even more.
There's a new
I mean, so when the Institute of Medicine says, hey, let nurse practitioners do what they do best and don't put barriers there. You know, why all the pushback?
I don't know, but it's not just that.
Money? Is it money? Is it all boiled down to money?
They get mad when we say turf battle. And we always, as nurses, we always circle back when they say, is this a turf battle? We say, we want accessible care for patients.
everybody.
We want to provide care in all settings and all availability, not just rural, but urban, that's underserved in HIPSA areas and things like that. But there's more than Institute of Medicine is the strongest one, but also American Enterprise Institute, the Heritage Foundation, Americans for Prosperities, everybody, FTC, they all have data, and that's not nursing influenced. So when they say nursing is just bringing out their data, it's everybody. It's the Governors Association. It's everybody.
Well, you can look at patient survey satisfaction forms too.
Yep.
I mean,
Yeah, and actually,
that doesn't, I mean, that's not influenced by, that's just their surveys.
yeah, they started saying that we should look at malpractice. So we did. We pulled all the data from our numbers, our identification numbers, where everything has to be logged. Well, guess what? They have 4 times more lawsuits. So it just, the whole thing is just mind boggling and crazy. The resistance that we get, and it's the same thing every time. Now, Kansas is about to roll to full practice. It's passed their Senate and moving to the House. It passed.
So are we
fully.
going to be completely surrounded by states?
Yes.
Full practice?
Yes.
Because
Missouri will
Kansas,
be standing alone by itself, where nobody, you know, hey, we've got to restrict them and keep them in their place, right? But
Yeah, and
all around us, it's going to be full practice authority.
yeah, so Kansas passed last week, and it should come for a vote in the Senate as soon as they get, I mean, the House, as soon as they get back from some break. And then Kentucky also last week passed the House, and now theirs is going to the Senate. So yes, we're going to be almost fully surrounded. And they see that, especially when they see that map with the red, green, yellow on it, and there's red right in the middle.
Oh, I want you to give me that map so I can post that on our website. We need to make this, and you know, our patients too, they need to advocate for nurse practitioners too with their legislators, and let them know when they're happy about the care we give, and that they feel that we give adequate care in our settings to practice in our scope of practice. So
there's a lot more data coming out too, because like Mizzou has that CMS grant, that demonstration grant. So the nursing homes have been looking at when you put, because a nursing home cannot hire a nurse practitioner. You have to be hired by the physician and assigned to work there. But so when you have a nurse practitioner,
that's just in Missouri.
Yeah.
Okay.
So when you have a nurse,
I keep bringing us back to that because I want our audience to hear these are Missouri issues.
Yeah. But when you put a nurse practitioner in the nursing home, they get to know the patients better, and they don't have as many rehospitalizations. They prevent complications. And so it saves the state a lot of money. And so they have that demonstration information that is tremendous because it's specific to Missouri, but also Johns Hopkins is putting out a lot of data that shows in states that went from limited scope of practice to full practice, that the nurse practitioners truly do move to the rural areas. When they don't have to be tied to where the physicians are, they actually do go back to where they live and work in the rural areas, because they always say they'll never go back to the rural. Well, we have data now from Johns Hopkins that should be out next month, but they shared with us at the conference last week that shows that it went from 21% in rural to 31% in rural. And in Nebraska, they went from 25 HIPSAs to 20 HIPSAs because of the shift of nurse practitioners.
Wow.
And so there's some really good data coming out.
Well, I mean, I loved working in rural health. And Margaret, as you know, I was there 7 years. And I mean, I would have stayed there my whole life. I really, you know, but my commute was just getting to a point where I couldn't see at night and those roads were dark, and I wasn't in a position I could move more rural because my son is in a high school and I didn't want to, you know, change schools for him. But it really, it broke my heart because that was the best job I ever had, the best patients. They were so grateful. And I can see why nurse practitioners are drawn to work in rural communities, and we need more of them. We don't need legislation that restricts us from being able to serve some of the most needy people that
Right.
they can find
Right.
somebody who cares for them in their own town. And we need our patients to speak up and tell our legislators in Missouri that, even though the lobbyists for the medical community and are strong, our voices have to be heard at some point to let nurse practitioners move to those areas and serve the people without so many restrictions.
Yeah, the legislators are starting to see that the physicians block not just nurse practitioners, but they've testified against speech and hearing. They've testified against physical therapy. They testified against dentists who wanted to be able to give vaccines. They've testified against dietitists. They've testified against everybody. So they're starting to see a trend, and they're starting to get the idea. And they've actually been really very good about hearing our bills and moving them forward this time and things. There's a lot of other crazy things, but we're running kind of long. So
Yeah.
do you want to know the other crazy things?
Yeah, give us a quick rundown.
This is real quick and dirty here. Senator Onder has 803 again. Remember, he's going to term out. So he's trying to get restraint of trade eliminated for all health professionals. It's not moving. It was assigned to committee, never heard. Another thing that's a crazy thing, and this is for RNs primarily, but it's HB 2605, and this is from Kurt Gregory, put it in. It's now called the Supplemental Healthcare Services Bill, but initially they were calling it on the side the Nurse Gouging Bill. And it is to stop people from travel nursing because they thought travel nursing was capitalizing. And especially when you heard testimony, you kind of felt for them because they said in the nursing homes and in the home health places, they're reimbursed by Medicaid and Medicare. And so it's limited. We all know they don't reimburse well. And so they have a limited budget. And when they have nurses coming in and suddenly go from making $23 an hour to making $65 an hour, it's not sustainable. But it turns out, we told them in testimony, the nurses aren't getting that money. It's the agency that's getting that money. And the agencies weren't making sure they sent qualified people. So people were leaving in the middle of the shift or not showing up or not certified in CPR or saying terrible things to the patients. And so they want in statute somewhere where it's capping now. Mona got it removed, that nursing capping of salary is not in there, but they can cap the amount that the agency can make. And the agency has to let the nurses know that it's hiring, and it hires all levels, that they have to pay their own taxes, and they have to guarantee that they have CPR certification and meet the criteria and are able to give medications and the things they say they're supposed to do. And that hospitals can refuse to have certain people, or agencies can refuse to have certain people come back. So that one's there. And really, I think we need to support our RNs because we want them to support us.
I really believe that we need to support our RNs. I mean, I'm sorry, but there's a lot of health facilities, big hospitals, big companies, and they don't pay our nurses well. And it's sometimes not even about pay, it's about safety. It's about, the nurse patient ratio. And so, maybe I'm hoping that will wake up some of the healthcare institutions to say, wow, we should pay our nurses better, and we need to treat them better. If anything, that I hope that wakes up the situation.
Yeah, it's about respect, and it's about moral distress. Some of these people, it's more moral distress. They're being put in positions to do things that morally they know are wrong, and they don't want to keep doing it, but they can't juggle all the balls.
No.
And so one of our complaints about this was, you negotiate with your administrators are still making money here.
Right.
And you negotiate with the physicians, you negotiate and reimburse higher in rural because you have a shortage there. We've had shortage with the nursing forever. You negotiate what you reimburse for like procedures and things like that with the insurance companies. Negotiate with these companies and don't put it in statute. But I'm afraid it has moved out.
Oh, that's a shame.
But at least it took out the nursing salaries.
Thank goodness. It needs to not. Yeah, we do not need to cap our nurses.
But it is unsustainable. At the same time, I can see where it's unsustainable. So something has to give.
Something has to change.
Yeah. Yeah.
We're going to have all contracted travel nurses, taking care of us.
Or we're not going to have any. And our hospitals, we've already lost 6 hospitals because of these. And so because those 6 hospitals are gone, that's why they started doing all this rally thing. But people are just gonna start going other places.
Right.
There are 7 other states with this same legislation moving forward.
Wow. Wow.
So it's something, and then federally, that legislation is moving forward because so many hospitals and actually the smaller agencies and the more rural agencies, those are the ones who are hurting the most
Yes.
from this. So that's one thing. Another thing, let's see, SB 1000, so Senate Bill 1000 by Senator Gannon and House Bill 1711, they match. And this is by Cindy Buchart. I think her new name's Courtway. But so those two have the legislation going forward for surgical smoke. I did not realize, and I had never heard of it before, but there's surgical smoke when you are doing electric cautery or
Yeah.
you are
Yeah,
doing
yeah.
laser and you're doing like cancerous or toxic things that goes in the air. And the people who are working those ORs, even with the masks on, they're ending up with a lot of upper respiratory cancer that's killing them.
Oh,
Oh,
wow, I didn't realize
I
that.
never heard it before, but we
Oh.
learned a lot about it by these guys. And so they want a plume, like a cover thing that does surgical smoke removal in any urgent care or hospital that is using any electrocautery or laser or anything that burns these, because it's the physicians that were doing a lot of surgical things on cancer that really have upper respiratory and throat.
yes. Oral
bound.
I could
cancers.
see, yeah, where that would happen.
Isn't that interesting? So neither one of those are really moving right now, but I'm sure we will bring it back next year because people just don't know about it.
Yeah, no, I want to know more about that. That's really interesting.
Yeah, it wouldn't move forward and go into effect until 1/1/2024 because it will take time to get the equipment and budget for it and all that
Yeah,
kind
but
of stuff.
that's a worthy, and
Yeah.
I never would have even thought about that.
I know, we didn't either. And so we had a big presentation on it to our committee before we thought about getting on board. And then we're all like, absolutely, we need to get on board with this. So that's a nursing kind of health kind of thing that we're backing and supporting. But right now, I think it's been assigned to the committee in the Senate, but it's also still not moving. So that's something to keep an eye on for the future. Other things, HB 2116, no patients left behind. Are left alone actually. And it's so that you can have your spouse or your, what do you call it? Your guardian, and then 3 additional people. And the thing that was amended onto that bill, because there were so many people dying alone and complaining to their legislators that I'm not sure my mother's wishes were carried out because I wasn't there to fight for them and all that kind of stuff. So there was actually very compelling testimony on this. And then what they amended on was that physicians could modify that all those people be accessible depending on what's going on with the patient and in the situation in the hospital. So that was actually a good amendment.
Yeah.
One really crazy thing that I want to tell you about before I let you go is that there's AP legislation, assistant physician legislation, and it's SB 938. And it had a hearing last week, and none of us really complained about it right now. And we're thinking it's the PAs that have to go forward with doing whatever they want to do with it. Because what this legislation says is that all assistant physicians can only be assistant physicians for 3 years. And after 3 years, if they don't have a place where they match to do their internship, they will be licensed as PAs. Is that possible?
What?
I don't know.
Wow, wait a minute.
The reason none of us stood up against it is because in that legislation, it also says you have to be an AP educated in a medical school in North America. So we have 330 APs in our state right now. And there are 2 other states that are looking at AP options. By putting that North America in, out of those 330, there's only 2 of them in there that are from Missouri. So we didn't contest it because it would get rid of most of those PAs. But I think really, truly, the PAs have to speak up and say,
Yeah.
they didn't have our training. They didn't
No.
take our boards. They can't be educated, but they realize they're all under the Board of Healing Arts. So the Board of Healing Arts thinks they can do that, just do that.
I can see them. I
Wow.
can see
So
that's
maybe
where they
it's a
went with that.
completely different track of training.
Isn't that crazy?
Wow.
And then there's
Yeah.
4 federal legislation things that are moving forward federally. So this is everybody, not just Missouri. And it's HR 1956 and Senate Bill 1986. It's for cardiopulmonary rehabilitation. And what happened is that we got the ability to do supervision, but not order it. So this would make the fix so that we could order and supervise it. It actually doesn't go into place until 2024. But we think that this one, it's got no budget associated with it. So it's like a no-brainer. So that's one thing. Another thing is HR 4870 and Senate Bill 800. That's to promote diabetic shoes. Yet again, we're trying to get diabetic shoes.
So we
Now,
can
if you're in-
sign that order.
If you're in one of the, there's a trick to that though, but if you're in one of the states or if you're in one of the organizations that is doing one of the CMS demonstration projects, you do have the ability to order everything, including diabetic shoes. And so they're kind of watching to see if it really has the impact that the cost that they say affiliated with it was. But do you know, when you have to send the person to your collaborating physician to sign for the diabetic shoes, it means that the physician has to take over care of that patient.
Oh,
Oh,
Did you realize that? So
wow.
none of us were doing that, but that is what the statute says, that they have to take over care, see that patient, and then take over care until they delegate it back to us. So you actually lose your patient by doing that, even though you may have been the
Wow.
only provider that they've
Now,
ever
can
seen.
podiatrists order diabetic shoes?
I don't think they can.
I mean, I'm just thinking, my
Yeah.
goodness, of
Yeah.
anybody who would be trained to order diabetic shoes, it would be
Yeah.
podiatry.
This was an oversight that happened when the Affordable Care Act, and if you remember, the Affordable Care Act was 800 pages long. And so, when they were striking things, remember at the end when they said some states don't have to do it and other states, and you can expand or you can use our agencies and things like that. When they were striking, it was mistakenly struck, and it has been trying to get it put back in ever since. But because it was part of the Affordable Care Act, there's always resistance. Plus, for some reason, they said there's a fiscal note on it because there's more people ordering. And so even people that say, oh yeah, that makes sense. Oh, there's a fiscal note. And then they don't vote for it. So it never gets very far. But so we bring that back every year. I personally think the shoes are ugly and you could buy better shoes just by getting good shoes someplace else. But they're free to the patient if we order them. So they want them. And here's the other interesting thing. One pair, if you deny them diabetic shoes, you could give them 2 pairs of diabetic shoes every year for 9 years, and it would equal the cost of the lesion and the care that you require for an ulcer on the foot. So really, it
Wow.
should be saving them money, but they don't look at that part. Okay, so that's the second one. The third one is HR 6087. This is for improving access to workers' comp, because right now, if you're injured on the job and you are a federal worker, you cannot see a nurse practitioner. A nurse practitioner can provide your care, but cannot extend workers' comp and certify workers' comp. And so since most nurse practitioners work in work comp areas, they want to extend that so nurse practitioners can sign for that. And that should actually be one that goes through easily. But that's one that's new on our hit list. And the last one is HR 6308. It does not have a matching Senate bill. It's for ACO Assignment Improvement Act. And it's because we can have patients that are in an ACO, but we cannot get benefit, and our patients don't get the benefit of the Medicaid Shared Savings Program. So they don't get the discounts that the physicians' patients get. They have to see a physician at least once a year. So in states where there's full practice authority and you don't have to see a physician at all, or you don't have a collaborating physician, they get penalized for being in those states and seeing a nurse practitioner. So this was just to balance the playing field, and CMS seems willing to push this forward. Somehow it just never gets on the cut because crazy things like wars and COVID come up.
yeah.
And
Yeah,
Wars and
Trump 'em.
COVID.
right.
Yeah, kind of crazy things. So anyway, I think that's pretty much,
That's a pretty full agenda.
yeah, there's a
So our
lot of
big
stuff
push
going
this
on.
year is to try to get some of those waivers back.
Yes.
We get the 75-mile rule rescinded out the door. And if we get anything else, it's a bonus, right?
Yep, that's right. That's right. Although I think we will get home health, and I think we will get the ability to do telehealth, which would really be good for all of us
Yes.
here in metropolitan areas.
Yes.
Margaret, you are an
Thank you, Margaret.
It's nice
asset.
talking to you guys.
You are a nurse practitioner who is changing practice.
Practice.
And
Yeah.
if there's any other people out there, any other nurse practitioners who are changing practice or students, please join us and listen to our podcast, support us so that we can keep bringing you these important information. Margaret, thank you so much for joining us.
Thank you.
Thanks for having me.
All right. Bye, guys.
Bye.